So, very good evening, everyone. I am Dr.satyabrata, MDDM clinical pharmacologist, and today I am going to discuss on newer drugs in leprosy. So, coming to introduction, one of the oldest diseases known to be the mankind and Mycobacterium leprae was one of the first bacillus to be discovered and associated with a disease, and advances in its management has been rather slow compared to other bacillary diseases due to peculiarities of this bacillus, indolent in nature, inability to grow in artificial media, etc. Disease, long incubation period, disease spectrum dependent on host immunity. Despite these shortcomings, great steps were made in the effective control and reaching the elimination target of leprosy in most countries, including India, chiefly due to the introduction of MDT, multi-drug therapy, in 1982 in its management. But it should be noted that leprosy continues to occur in most parts of endemic countries in good numbers. Then significant landmark in the treatment of leprosy. 1854, the first medication which definitely seems to have some degree of activity against Mycobacterium leprae was Kaulmogra oil. No effective therapy until 1941 except isolation of segregation. In 1941, dye-substituted derivative of dapsone, promine, used IV, and 1949 oral dapsone was used. 1962 clofazimine was reported to have anti-leprosy activity. 1964 first case of dapsone resistance was reported. 1970 most potent bactericidal drug rifampicin was first used. Its predecessor rifamycin SB used parenterally in early 1960. 1972 combination of rifampicin and acidapsone to reduce drug resistance. 1982 WHO recommended MDT, multi-drug therapy, for both MB multibacillary and PB possibacillary patient. Then shift from monotherapy to MDT, multi-drug therapy. Reasons being to reduce the post-treatment relapse, to reduce the side effect, to increase the cost effectiveness by a shorter duration of treatment, leading to a earlier release of patients from control. Then issues related to MDT, multi-drug therapy. 1981, WHO recommended to treat multibacillary cases till 2 consecutive skin smear negative. 1992, fixed duration therapy, FDT, was introduced where MB multibacillary patients were given treatment for 2 years or 24 pulses in a period of 36 months. 1995, WHO redefined the therapy with 12 pulses of MDT MB and recommended to stop treatment at the end of 12 months or if 12 pulses were completed in a period of 18 months. Skin smear examination was not mandatory. Duration of PB therapy, possibly not changed since WHO's first recommendation and remains for 6 months or 6 pulses to be completed within 9 months. SLPP, which were single dose rifampicin 600 mg, ofloxacin 400 mg, and minocycline 100 mg. ROM therapy was recommended on the basis of a multicenter double-blind field trial conducted in India, withdrawn quietly over next 5 years. SLPP means single lesion possibacillary leprosy. Then coming to disadvantage of MDT, multi-drug therapy. From a public health care point of view, the current MDT regimen has proved to be very effective in the elimination of leprosy. However, many experienced dermatologists find that the clinical cure does not occur after MDT in all cases of leprosy. Clinically cured patients at the end of 12 months of MDT can still be bacteriologically active, and bacteriologically negative patients can still be clinically active. Then coming to limitation of FD, MB, MDT. The persistence of viable drug sensitive bacilli, dormant bacilli that have escaped the bactericidal effect of drugs rifampicin in few patients. LL, lepromatous leprosy patients with high initial BI bacterial index have naturally a poor CMI, cell-mediated immunity, and macrophage functioning to deal with these remaining organisms. Observe that the bacteriological relapses occurred earlier than clinical worsening, and this could not be picked up in many studies with a short follow-up period, as slit skin smear is not routinely being used in the fields. The endpoint of treatment of pure neuritic leprosy is difficult to establish due to the highly controversial assessment and cure criteria. Then endpoint of treatment of PB, postbacillary leprosy cases, limitation of FD, PB, MDT. Endpoint of treatment of PB, postbacillary cases, smear negative patients, more difficult to define, unlike in MB, multibacillary cases, wherein the slit skin smear are indicators of disease activity. Continued visibility of a clinically active patch in some patients at the end of 6 months of therapy has been observed. Duration of treatment is not long enough for the body to clear out the bacteria. Continued inflammatory response results in persistent clinical activity for up to 12 to 18 months. Studies at the Central Jalma Institute of Leprosy, CJLI, Agra, India, good number of patients diagnosed as PB, possibacillary leprosy, clinically were acid-fast bacilli positive, indicating their chances of getting inadequate treatment and prone for relapse. Then solution to overcome these problems. MB, multibacillary cases with an initial average BI bacterial index more than equal to 4 plus should receive at least 4 years of standard WHO MDT multidrug therapy as proposed by the Marchok's chemotherapy study group. An additional 12 months of MDT multidrug therapy for MB leprosy with high initial BI bacterial index for patients showing evidence of deterioration as per WHO. The addition of immunotherapy by the BCG, Bacillus calmette guerin, or other vaccines help to reduce the duration of the treatment by 50%. Addition of ofloxacin and minocycline at a monthly dose to the existing MDT multidrug therapy as per the trials conducted by the NLEP, National Leprosy Elimination Program, and CJLI. Rigorous annual follow-up for more than equal to 5 years for PB possibacillary cases and more than equal to 10 years for MB multibacillary cases after being released from FD MDT is essential. For MB leprosy, 24 monthly doses pulsed of supervised ROM regimen can be advocated for patients refusing or unable to take MDT multidrug therapy. Development of new and effective anti-leprosy drugs. Coming to newer drugs and regimens. So need for newer agents. From the operational point of view, duration of treatment is still too long. MB, multibacillary leprosy. Two drugs, that is dapsone and clofazimine, are only weak bactericidal against Mycobacterium leprae. Further shortening the duration of treatment by this regimen might result in high relapse rate. Administration of the daily components, dapsone and clofazimine, cannot be supervised. Patients who cannot tolerate any of the drugs in MDT MB need a safer and effective alternative. Resistance in components of the present MDT has been reported since the 1960 dapsone DDS in 1964, rifampicin RPM in 1976, clofazimine in 1982. Hence, the ever-changing pattern of drug resistance dictates the need for new drugs. Then newer drugs. Currently, these drugs are in various stages of development in both in vitro and in vivo studies, and some of them have shown desirable results in clinical trials of various sample sizes. Fluoroquinolones, ofloxacin, sparfloxacin, prifloxacin, lomifloxacin, clinafloxacin, temafloxacin, moxifloxacin, macrolides, clarithromycin, roxithromycin, telithromycin, ketolides, tetracyclines, minocycline, ansamycins, rifapentins, rifabutine, benzophenoxazine, rifamycin, N2-naphthyl glycine hydrazide, T9, KRM1648, KRM2312, beta-lactamase resistant antibiotics, amoxiclav, cephaloridine, cefuroxime, cefoxitin, dihydrofolate reductase, DHFR inhibitors. Rhodimoprim and epiroprime, K130, fusidic acid derivatives, deoxyfructoserotonin. Then some other drugs having high bactericidal activity against Mycobacterium leprae in animal and human trials. MRRI, mycobacterial ribonucleotide reductase inhibitors, acetylpyridine Thiosemicarbazone, heterocyclic thiosemicarbazone derivative 1 to 26, phenazine compound B4100, B4071, B4087, B746, B663, pyrazinamide, aminoglycoside, tyrosinase inhibitors, diflunisal, indole 2 carboxylic acid, calcitriol, metallic chelators, exohalins, indium, scandium derivatives, gangliosides, chronaceal, polychlorocarbonic acid derivatives, deutephone, antimetabolite, dithiocarbamate. Then coming to fluoroquinolones, effective against both gram-positive and gram-negative bacteria. Pfloxacin, ofloxacin, sparfloxacin, and moxifloxacin have been shown to possess a marked antimicrobacterial effect. Mechanism of action: inhibit bacterial DNA gyrase in gram-negative, interfere with strand cutting and resealing function, damage DNA and digestion of DNA by endonuclease, bactericidal, inhibit topoisomerase 4 in gram-positive. Then ofloxacin, preferred as the other two drugs, need to be given in a very high dose to achieve the same effect as ofloxacin 400 mg OD once daily. Then available as 200 mg and 400 mg tablet. Bactericidal against Mycobacterium leprae, less than a single dose of rifampicin. When given daily for 22 days, it killed 99% of the viable organisms. Rapidly absorbed from GIT, gastrointestinal tract, widely distributed in body tissues and concentrated in the bile. Side effect: photosensitivity, joint pain, nausea and vomiting, abdominal problem, impaired cartilage formation. So contraindicated in pregnancy and children less than 18 years. So pregnancy category C. Now there is no category A, category only risk versus benefit analysis in case of pregnancy. PLLR rule is there. Pregnancy lactation labeling rule. A much longer course of treatment is required in leprosy, and their safety in long-term use has not been detailed. To reduce or minimize future emergence of resistance, it is essential to use it only as a component of MDT multidrug therapy and never alone, at least for mycobacterial infections. Help in shortening the length of treatment and reduce the chances of drug resistance. In recent study, moxifloxacin 400 mg once daily has been found to be more effective and much more powerful than ofloxacin, with less side effects and as active as rifampicin, a promising newer anti-leprosy drug available as 400 mg tablet emcin emlone. Then macrolides, bactericidal against variety of gram-positive organisms. Several members of this group have been evaluated and clarithromycin appears to be promising. Others, roxithromycin and telithromycin. Mechanism of action: reversibly bind with P site of 50S ribosomal subunit. Dissociation of peptidyl tRNA from ribosome. Inhibit protein synthesis and bacterial growth. That is depicted in the picture. Then half-life 6 to 7 hours and MIC, minimum inhibitor concentration 0.125 mg per ml. Absorption is affected by high gastric pH, hence the need for enteric-coated tablets. Undergoes rapid biodegradation to get converted into active 14 hydroxy metabolite, being lipid soluble, extensively distributed both in body fluids and tissues. Daily administration of 500 mg of clarithromycin kills 99% of viable Mycobacterium leprae within 28 days and 99.9% by 56 days. Available as 250 and 500 mg tablet. The concurrent administration of rifampicin decreased serum clarithromycin concentration by 80%. However, the concentration of biologically active 14 hydroxy metabolite remains unchanged in serum. Inhibit hepatic cytochrome P450, decreases clearance of drugs dependent on it. Side effects are nausea, diarrhea, dyspepsia, abdominal pain, and headache. Most frequently reported adverse events, and most of these effects are considered mild and unrelated to age. Then pregnancy category C, but now it is not pregnancy category C. There is no category of pregnancy. It is according to PLLR rule, that is pregnancy lactation labeling rule. It should be the risk versus benefit analysis to be done. Then coming to telithromycin. Telithromycin is HMR 3647 RU 66647 is a ketolide, a new class of macrolide possessing a 14-membered ring and exhibits strong activity against gram-positive bacteria, including mycobacteria. Diseases displays significant bactericidal activity against mycobacterium leprae equal to or slightly greater than clarithromycin. Available as 400 mg tab Ketek and metabolized mainly in the liver. Most common side effects: diarrhea, nausea, abdominal pain, vomiting, headache, and taste disturbances. Rare but severe side effects reported in fulminant hepatitis and hepatic necrosis, and contraindicated in myasthenia gravis, jaundice, hypersensitivity, and at that time that is pregnancy category B, but now it is PLL rule, pregnancy lactation liability rule, and risk versus benefit analysis to be monitored. Then coming to minocycline only tetracycline which exhibits significant activity against Mycobacterium leprae. Because of its lipophilicity, it can penetrate the bacterial cell wall. It is bactericidal against Mycobacterium leprae but lesser than rifampicin. Mechanism of action: binds reversibly to the 30th unit of the ribosome, blocks the binding of amino cell transfer RNA to the messenger RNA ribosomal complex, inhibits protein synthesis. This is the 30S and 50S structure gives shown in this figure, and it will bind to the 30S ribosome. Then peak plasma concentration occur within 1 to 4 hours. Serum half-life is about 12 to 30 hours, and MIC minimum invasive concentration 0.2 microgram per ml. Metabolized in the liver and is eliminated both in urine and feces. In a 100 mg daily dose, it kills 99% of Mycobacterium leprae in 28 days and 99.9% in 56 days. So available as 50 mg and 100 mg tablet and capsule. After weeks treatment, decrease in erythema and induration has been reported. Nasal symptoms in lepromatous leprosy patients responded well. Apart from cutaneous pigmentation, it may cause vestibular disturbance, gastric intolerance, and early-like reaction, and benign intracranial hypotension, and it is given that pregnancy category D, but nowadays it is PLL rule is there, pregnancy lactation labeling rule. According to that, risk versus benefit analysis to be done. Then anasamycins, semi-synthetic derivatives of rifampicin. Rifampicin, rifabutin, R71-1, R76-1, benzophenoxazine, rifamycin, N2 glycine hydrazide, T9, KRM1648, KRM2312. Mechanism of action: binds to beta subunit of DNA dependent RNA polymerase enzyme complex, inhibit transcription of mRNA, inhibit protein synthesis. So this is the picture showing the mechanism of anasamycin. Then rifabutin, found to be more active than rifampicin. Rifampicin, more active against Mycobacterium leprae than rifampicin, the minimum effective dose being 8 times less. Another promising newer anti-leprosy drug. Significantly higher peak serum concentration and a much longer serum half-life. Some study reported complete Mycobacterium leprae killing in 7 days. A single dose of a rifampicin plus moxifloxacin plus minocycline combination killed 50 times more Mycobacterium leprae than a single dose of rifampicin plus ofloxacin plus minocycline. Jaundice and severe ENL, erythema nodosum leprosum, significant side effect, and it is written pregnancy category C, but nowadays it is PLL according to PLL rule, pregnancy lactation labeling rule, and risk versus benefit analysis to be done. Despite above advantage, future role still remains doubtful because of same mode of action as rifampicin, hence cross resistance, severe side effect, and high cost. Then coming beta lactamase resistant antibiotics. Mycobacteria produce beta lactamase, an enzyme capable of breaking beta lactam ring of penicillin, and that leads to basic penicillin are not effective, and it includes cephalosporins and penicillin with clavulanic acid. Cephaloridin Cephaloglycin, 7-amino cephalosporanic acid, and cefoxitin found to inhibit Mycobacterium leprae multiplication, but because of their high cost, parenteral mode of administration, and short half-life, are unlikely to find a place in treatment of leprosy. And so, no trials have been considered. A combination of clavulanic acid plus amoxicillin is effective against drug-sensitive and dapsone or rifampicin-resistant strains of Mycobacterium leprae. Frequent GI gastrointestinal side effect has been observed with sulbactam and amoxicillin. Trials with ampicillin are underway. You can go through the article to find out whether the trial is completed or not. Dihydrofolate reductase inhibitor. Combination of sulfonamide and trimethoprim are effective against most of the bacteria sequential blockage, but not useful against mycobacteria due to inability of trimethoprim to enter mycobacterial cells. Three derivatives of trimethoprim, that is brodimoprim, epiromoprim, and K130, have been found to easily penetrate the cell. All are effective against Mycobacterium leprae in mice, have shown synergy with dapsone. Pteridine plus PABA, it lead to dihydrofolic acid, then tetrahydrofolic acid, then purine and pyrimidine synthesis. Sulfonamide dapsone inhibit dihydropteroic acid synthase, and dihydrofolic acid cannot be formed, and purine pyrimidine cannot be, synthesis cannot be happen. But trimethoprim and brodimoprim, it inhibits the dihydrofolate reductase that convert dihydrofolic acid to tetrahydrofolic acid in this pathway. If trimethoprim block this pathway, then also purine and pyrimidine synthesis will be hampered. Then trial in leprosy are already underway. Some study reported that the treatment with a combination of 200 mg brodimoprim plus 25 mg DDS and 600 mg of rifampicin daily was completely stopped after 3 months because of excellent clinical results. Then coming to fusidic acid, steroid antibiotic used both systemically and topically against resistant staphylococcal infection. There has been a lot of interest in this compound in recent years because acts via inhibiting bacterial protein synthesis by preventing translocation of EFG from the ribosome, yet another step in sequential blockage. Has high lipophilicity with resultant higher intracellular concentration, attains high serum levels, and has long shelf half-life. It is its safety profile. EFG GTP for translocation. And this is the mechanism fusidic acid. It inhibits the bacterial protein synthesis by preventing the EFG from the ribosome. That is shown in this picture. Then in vitro radiorespiratory method, powerful action against Mycobacterium leprae almost equals that of rifampicin. Trials with daily dose of 500 mg and 750 mg marked improvement in 3 patients and moderate in remaining 6, available as 250 and 500 mg tab-fusidine. Nearly 99.5% viable bacilli killed in 6 weeks with no difference in response between 500 mg and 750 mg dose. There may be a simultaneous suppression of reversal reaction due its immunosuppressive activity observed in above trial. Should not be used alone. Given with rifampicin, its action is synergistic. Side effect rhabdomyolysis should not be taken with statins. Liver toxicity monitoring, liver function test when taken with rifampicin. Then deoxyfructoserotonin, DFS, normal human metabolite present in serum, being a natural occurring metabolite which, like serotonin, has its origin in tryptophan in the food, so-called anti-leprosy nutriment. In clinical trials, it shows a definite inhibitory effect on the multiplication of Mycobacterium leprae. They not only showed clinical but bacteriological and histopathological improvement without any side effect. Faster decrease in bacterial index (BI) and histological upgrading due to its immune stimulating effect. Killing of bacilli within the Schwann cells and macrophage. Protection of nerve damage and decrease attachment oblique uptake of Mycobacterium leprae by the cultured Schwann cell has been observed. Then neurphenazine derivatives. These are derivatives of clofazimine derived by halogenation bromo oblique chloro of the parent drug para-anilo group at its 3,7 position. Then 7 new drugs in this category are under trial both in vitro and in vivo. Compared to clofazimine, found to be more effective against Mycobacterium leprae. Their MIC minimum in vitro concentration 0.03 to 0.20 microgram per ml. MIC minimum in vitro concentration of clofazimine is 0.30 microgram per ml. Mouse foot pad studies favorable results when compared to clofazimine, particularly for B4071 and B4100. The other drugs in this group are B746, B3770, B3786, B4019 and B4087. Then benzyl amines. Compound 93 N-methyl-3,5-dichlorobenzylamine hydrochloride in mouse foot pad studies in combination therapy with dapsone and rifampicin has shown strong synergism with good clinical response and tolerability at high dose. Though it shows rapid development of resistance as monotherapy, this drug can form part of the combination regimen. Hydrazones. Besides its side effects on skin, liver, and bone marrow, thiazolone 150 mg OD once daily is found to show very good synergism with rifampicin dapsone by inhibiting bacterial ribonucleotide reductase to inhibit DNA synthesis. Diusiphone found to complement dapsone action by increasing its bacterial killing, decreasing its side effect, and decreasing reactional episodes. Then coming to newer MDT regimens. For multibacillary cases, rifampicin susceptible multibacillary patient, fully supervisable monthly administered regimen, rifampicin 900 mg or rifampicin 600 mg plus moxifloxacin 400 mg and clarithromycin 1000 mg or minocycline 200 mg administered once monthly under supervision for 12 months. Then rifampicin resistant MB multibacillary patient, leprosy patient, fully supervised regimen in 2 phases. An initial 6-month intensive phase followed by an 18-month continuation phase. So regimen 1, intensive phase, moxifloxacin 400 mg plus clofazimine 50 mg plus clarithromycin 500 mg plus minocycline 100 mg taken daily. Then continuation phase, moxifloxacin 400 mg plus clarithromycin 1000 mg plus minocycline 200 mg all taken once monthly. Then regimen 2, daily intensive phase, daily administration of 50 mg clofazimine with 2 of the following drugs: 400 mg ofloxacin, 100 mg minocycline, 500 mg clarithromycin. Continuation phase, daily administration of 50 mg clofazimine together with 100 mg minocycline or 400 mg ofloxacin. If available, ofloxacin may be replaced by moxifloxacin 400 mg, which has stronger bactericidal activity against Mycobacterium leprae. So fully supervisable monthly administered regimens, ROM combination, rifampicin 600 mg, ofloxacin 400 mg and minocycline 100 mg for 12 months. PMM combinations, rifampicin 600 mg, moxifloxacin 400 mg, minocycline 100 mg, PMM for 12 months. Then 6-week quadruple regimen, rifampicin 600 mg plus ofloxacin 400 mg plus clofazimine 100 mg plus minocycline 100 mg once a week for 6 weeks. Then once a month supervised rifampicin 600 mg plus ofloxacin 400 mg plus minocycline 100 mg in addition to self-administered dapsone 100 mg plus clofazimine 50 mg daily for 12 months. Then daily rifampicin 600 mg plus sparfloxacin 200 mg plus clarithromycin 500 mg plus minocycline 100 mg for 12 weeks. Then patient refused to take clofazimine, then rifampicin 600 mg, ofloxacin 400 mg plus minocycline 100 mg once a month for 24 months. For PB, possibacillary cases, single dose of ROM or RMM for all possibacillary cases. 4-week ofloxacin containing regimen, rifampicin 600 mg and ofloxacin 400 mg given in supervised doses daily for 4 weeks. Then once a month ROM for 6 months. Rifampicin, ofloxacin, minocycline. Then accompanied MDT, multi-drug therapy, recommended by WHO, an innovative approach to ensure the underserved groups to have access to MDT, multi-drug therapy, and other services. Patient is provided the entire supply of MDT, multi-drug therapy, at the time of diagnosis, while someone close to patient assumes the responsibility of helping him or her complete a full course of treatment. Simple but a wrong solution for implementing supervised therapy because of confused operational difficulties with technical justifications. Ignores the facts of poor adherence of leprosy patients to self-medication completely. Lacks evidence-based justification and neglects the importance of regular contacts between healthcare workers and patients, which is crucial for the prevention of impairment. Then Uniform MDT, multi-drug therapy, a research project where patients are provided 6 months of MDT, multi-drug therapy, for all types of leprosy and assessed for treatment response in terms of relapse. Advantages: it could be effective and operationally convenient in the context of integration of leprosy into general healthcare services. Drug compliance with a shorter duration can make it an acceptable regimen for multivascular leprosy. Clofazimine-related pigmentation of the skin is usually short-lived and acceptable to PB possivascular patients. As continued inflammatory response results in persistent activity in leprosy, addition of clofazimine can help in possivascular PB patients. Then granulomas regressed faster if clofazimine was added to the PB possivascular leprosy. Then the disadvantage is UMDT, uniform MDT multi-drug therapy, will overtreat PB possivascular leprosy patients and undertreat MB multivascular patients, especially those with a high initial BI bacterial index. Then newer drugs for lepra reaction. So besides the conventional drugs like prednisolone, clofazimine and thalidomide for reactions, certain other drugs and combination regimens are now available, and some of these includes zinc, given as zinc sulfate formulation 220 mg per day for 4 months, resulted in marked reduction in the steroid requirement. This will decrease the incidence, duration, and severity of reaction. Anti-inflammatory function, inhibition of complement-dependent immune complex reaction, inhibition of T cell activation, inhibition of neutrophil chemotaxis. Then levamisole, given at the dose of 150 mg twice weekly for up to 6 weeks with dapsone, found to decrease the incidence of reaction and results in clinical improvement of lesions as compared to placebo. Then pentoxifylline, methylxanthine derivative, given at the dose of 1200 mg per day in 3 divided doses, found to be well tolerated and effective in type 2 lepra reaction, more so in HIV, human immunodeficiency virus positive cases in whom long-term steroids therapy is contraindicated. Then pulse corticosteroid therapy, using infusion of 40 mg betamethasone daily for 3 days in a month, though well tolerated, did not offer any significant advantage over the conventional management. It is possible that at higher dose in combination with an immunosuppressant like cyclophosphamide, pulse therapy could reduce steroid dependence and related problems. Then methotrexate, found to be effective as a steroid sparing agent in a case of steroid resistant cases, acts by increasing adenosine level, in decreasing pro-inflammatory cytokine and increasing anti-inflammatory cytokines. Then leukotriene inhibitors, Zafirlukast, Montelukast, has been tried in an open phase 2 cohort with dose of 40 mg BD twice daily and was found effective, but endpoints are not defined. Then thalidomide derivatives, Revlimid, Actimid, more potent than thalidomide and do not appear to have any side effects, but requires clinical trials. Then infliximab, you can go through the details in articles about thalidomide derivatives used in leprosy. Then coming to infliximab, TNF alpha antibody suppresses the biological activity of TNF, tumor necrosis factor, by binding to it. Reported to be effective in a single case of recurrent ENL, erythema nodosum leprosum, could be Another approach for chronic ENL, eosinophilic leprosy. Other drugs like cyclosporine, chloroquine, and azathioprine have been in use recently for the management of reaction, though their exact indications still need to be worked out. Then coming to conclusion, newer drugs and regimens hold a great promise but have to be observed carefully for their long-term efficacy. They should never be tried as monotherapy to prevent resistance. Most of the newer drugs are bactericidal and hence helps in reducing the duration of treatment. But many are in clinical trial and not available in India. Further research is required into an important area to find new drugs or combinations of drugs capable of eradicating persisting organism and eliminating Mycobacterium leprae derived antigens causing adverse reaction and nerve damage. So that's all for today's session. You can ask questions in the comment box and I will try to answer your questions. So please like and subscribe my channel and also share the videos to your near and dear so that they can also gain some knowledge about different diseases and their management and also on clinical trials and different topics. And if you want to know more and more, then you can go through the original articles and published in reputed journals and also guidelines about the diseases and their management. So different diseases and their management guidelines you can go through to learn more and more. So that's all for today, and we'll meet again on the next day. So thank you very much. Thank you again. Jai Jagannath.